Hello, everyone. We're going to continue today on the anatomy section, and I'm going to speak about the upper limb anatomy. And like we classified the lower limb into osteology and muscles, and then tendons or ligaments, and then nerves and blood vessels, we're going to do pretty much similar thing in here. So, starting the upper limb, traditionally it also starts by the breast anatomy. Breast is usually involved in the upper limb and not the chest. And then we're going to take the osteology of the upper limb, and then we're going to move on to the muscles of the upper limb, and then we're going to move into the nerves of the upper limb, including the nerve injuries, starting from the brachial plexus and how is it formed, and the surface anatomy, and moving on to some special nerves like median nerve, ulnar nerve, and radial nerve, and also the axillary nerve as well. And also we're going to talk about some injuries. We have some cool pictures in here to explain everything in detail, and then we're going to talk about some spaces in the upper limb, and that include quadrangular space and cubital fossa and the carpal tunnel syndrome, and then anatomical snuff box and so on. And finally, the blood vessels, and they include the axillary artery and the brachial artery and so on. All right, so we're going to start by looking at this photo. So this looks like a mammogram of the breast. So the first question is actually asking, what is this investigation? So this is a mammogram of the breast. And then it's asking to describe the anatomy of the breast parenchyma. So bottom line, you need to summarize all of this. You don't really need to remember word to word. So looking at this one, the breast is basically formed of a stroma, which is sort of fatty content. All right, so these are the stroma, and you have lots of lobules. All right, and also the ducts, and obviously the all drain into the nipple. All right, so you just need to mention like single word about maybe each one of them: the stroma, the ducts, and the nipple, and the lobules. So the gland and the duct tissue is arranged in variable amount with intervening fat. Like I mentioned, it's duct and gland, or the lobules, and also the fat. The terminal duct, they are usually from 10 to 20 lactiferous duct, and they open separately on the skin. They don't unite into a single duct, so they usually open separately, as you can see in here. And a glandular breast is supported by lots of fibrous septa in between, and this fibrous septa is usually attached to a fascia in here as well, and these called the Cooper's ligament. All right, the Cooper's ligament. All right, so this is just very quickly the basic anatomy of the breast. What are the patterns of lymphatic drainage of the breast? So the breast, obviously, if we're going to look from the front in here, so obviously this is the breast. So you have from the lateral side, it will all go to the axilla. And in the axilla, you can have anatomical classification of these lymph node, and these anatomical classification could be apical, and this in the apex of the axilla, and also central, and you have lateral or humeral group, and medial or pectoral group as well, and anterior and posterior group, right? So apical is the same as central, anterior and posterior group as well. However, we can classify them as one into a functional group, okay, or levels. And these levels will be divided based on a muscle called the pectoralis minor, which is this muscle. You will have a group of lymph nodes below the pectoralis minor, and these are level 1. And posterior to the pectoralis minor, these are level 2. And above or medial to the pectoralis minor, and these are level 3. This is not the only lymphatic drainage of the breast. It can also go to supraclavicular lymph nodes right there, and internal mammary lymph nodes on the medial side, and also infraclavicular lymph nodes as well, which will be sort of here. So these are all the lymph nodes for the breast or the lymphatic drainage. Like I mentioned, mainly axillary lymph nodes, and then can go to the internal thoracic lymph nodes. All of these are multiple valves channels, and that will make it easier for the metastasis to metastasize through the lymph nodes. And some other lymph nodes like infraclavicular, supraclavicular, subscapular, interpectoral, rectus sheath, and the other breast as well, and also mediastinal lymph nodes. But mainly what you need to remember from here, axillary and internal mammary, suprascapular, infrascapular, and maybe the other breast as well. All right. Moving forward, what is the blood supply of the breast? So usually you have the subclavian artery on both sides. So obviously you have the aortic arch, and you have the left subclavian artery coming separately, and then the common carotid artery, and then you have the brachiocephalic, which gives the common carotid artery and the subclavian artery. So this subclavian artery gives a branch called the internal mammary artery, and also gives something called the thyrocervical trunk, the the thoracoacromial artery, and also the lateral thoracic artery as well. So these are the two more branches for the arterial supply of the breast, and the venous drainage will usually follow the same. And sometimes it will take some blood supply from the intercostal arteries as well, from the intercostal arteries. The breast is a modified sweat gland, and it's a modified apocrine sweat gland. This is the type of the sweat gland that the breast is modified from. Moving forward, so this is a bone. You will be asked to identify what bone it is. So obviously from the look, this is the clavicle. Number two, we need to identify which side of the body is this clavicle, right? So this is the clavicle, and which side of the body is this clavicle. So initially we need to tell which side is medial and which side is lateral. So usually the medial side will be the round side, and the lateral side is, so this is the sternal side, which is sort of round, and the flat side is the lateral side, all right, or the acromial side, okay, the acromial or lateral side. So if you identified which side is flat and which side is round, so you will be able to identify whether it's left or right. So obviously from this one, this looks like the left clavicle, okay? And obviously the anterior surface will be convex in the medial two-third and concave, concave in the medial two-third and convex in the lateral third. So this is anterior and that is posterior, okay? So identifying the structures in here, so you have number 5 at the sternal end, and number 1 at the acromial end of the clavicle, and number 3 is the shaft of the clavicle, all right? And number 4 and 6, these are tubercles, right? So 4 is impression for costo-clavicular ligament, which is coming from the ribs to the clavicle, and number 6 is basically an impression for the acromial ligament on the other side, and 2 is something called the conoid tubercle, all right? So let's move forward. This is again a clavicle in here. To identify the structure, let's identify which clavicle it is, whether it's left or right. So the round end, like we said here, so the round end is usually the medial end. So the round is the medial or sternal end of the clavicle, and the flat is the lateral end or the acromial end of the clavicle. And also, again, as we said, if we identified, we need now to identify which is anterior and which is posterior. So now we know this is the medial end and this is the lateral end. So which is anterior now? So usually it's convex on the medial two-third. So now this is anterior, and concave in the lateral third. Yeah, obviously this is anterior and that is posterior. So again, that will be the left clavicle as well, right? So as you see here, this is the acromial end, and this is the sternal end, and obviously this is anterior and posterior, so that would be the left clavicle. You will have, this is the shaft, which is right there, and well, have also the conoid tubercle somewhere, but I can't really see it on this one. Moving forward with osteology, you have, this is the scapula, and in terms of the scapula, you have the anterior surface and the posterior surface. This is anterior and this is posterior. How did I know? Is by presence of number 10. So number 10 is the scapular spine. So this is the spine of the scapula. And the spine will end by a process that's called the coracoid, the acromial, right? The acromial process, right? So 2 is the acromial. And also this surface is called the subscapular fossa. And here, this is the spine. So you have a fossa here, which is called the supraspinous fossa. And here you have the infraspinous fossa. In terms of the borders, you have number 8 as, so this is 8 as the medial border, and number 6 as the lateral border, and obviously this is the superior border. Number 14 is something called the suprascapular notch for the suprascapular nerve, and number 3 is the coracoid process. Lots of questions on the scapula. So we kind of start this. So now we know all the structures. So we kind of start this. So obviously this is the spine. Above the spine, there is a muscle that comes from here in the supraspinous fossa. So it's called supraspinous muscle. And it goes to the greater tuberosity of the humerus. And then you have another muscles just below the spine coming from here. And this muscle is called the infraspinous muscle because it's on the infraspinous fossa. And you have another muscles coming from the medial, the lateral border, like that, upper 2/3 of the lateral border, going all the way up, right, like that. So basically, all of them will go to the greater trochanter, or the greater tuberosity, the trochanter than the femur, all right? So these muscles are the rotator cuff muscles, 3 of the rotator cuff muscles on the posterior surface. So you have supraspinous and infraspinous, and also the teres minor muscle, the teres minor muscle, okay? There is another muscle from the front which will take all this area that is called subscapular muscle as well. This subscapular muscle, this is the 4th muscle of the rotator cuff muscles. All right. What else? We can also be asked in here about the muscles attached to the coracoid process. So you have all of them will start by coraco, because this is the coracoid process. So you have coraco. I mean, not all of them really. You have the teres. The pectoralis minor is attached to it. Pectoralis minor related to it, and the coracobrachialis muscle is also related to it, and you have part of the biceps will be coming from it as well. We're coming to this. So yeah, we identified all the structure, and the attachment for 3 is coracobrachialis, pectoralis minor, and the biceps. Coracobrachialis, pectoralis minor, and the biceps, which are the muscles on the front of the arm. Okay. Moving forward, again, we're still in the scapula, but this is sort of a Y view or a scapula view. So it looks like a Y as you see, and sometimes we do this as an X-ray as well. Remember, we talked about the spinous process. We'll see this is the spinous process, and this is the lateral border in there. And yeah, this is the glenoid cavity. So 3 is the glenoid cavity. As you can see, the glenoid cavity is very shallow, and that makes the shoulder unstable joint. And on the top of this glenoid cavity, there is supraglenoid tuberosity and then infraglenoid tubercle. So supraglenoid tubercle and infraglenoid tubercle. And these give sort of an origin to the biceps muscle. So biceps comes from here, which is the long head of biceps and the long head of triceps for the inferior or the infraglenoid tubercle, right? So again, the same thing. So you have here, this is the coracoid process, and one is the acromion, and the spine is basically this area, and you have on this side will be the subscapular fossa, and this is the infraspinous, and this is the supraspinous fossa for all the muscles. So we talked about the glenoid cavity, infraglenoid tubercle, long head of triceps, and supraglenoid tubercle, which is the long head of biceps muscle, right? What is the surface marking of coracoid process? And we're looking for this one. So if you have the clavicle is this long, so it will be sort of the relation between the lateral quadrant and the medial 3 quadrant. That will be where the coracoid process lie. So in the following, we're going to identify the humerus, and we're going to identify a few structures and the muscles attached to it. So starting by this, I think it would be quite difficult to get the whole humerus on one side, but obviously that's the top end or the proximal end of the humerus. First of all, we need to identify whether this is the right or left humerus. So usually you hold the head and point it medially. So obviously the head would be towards the medial side, okay? And that would be the lateral side. And then you need to identify which is anterior, which is posterior. Usually anterior, there is a groove in here, which is this groove, number 6, and it's called the bicipital groove, all right? The bicipital groove. So if you've done this, so that looks like a right humerus, right? So that would be right humerus. And from now on, for any identification, we need to specify that this is the right humerus. So for example, we have number 5, and that looks like the head of the right humerus. And number 1 is the anatomical neck of the right humerus. So I specified that this is the anatomical neck. That means there is a surgical neck as well. And number 10 is the surgical neck of the humerus. And you have here a small tubercle that's called the lesser tubercle. And the lesser tubercle represents an attachment to the subscapularis muscle. The subscapularis muscle. So number 3 is the greater tuberosity. And the greater tuberosity represents an attachment to 3 muscles, which are the supraspinous muscle and the infraspinous muscle, and finally the teres minor muscle. The teres minor muscle. And those 4 muscles are the rotator cuff muscles, which play a very important role in stabilizing the shoulder joint, which is already weak. All right. We'll see that's the medial border, and this is the anterior border of it. So we talked about the anatomical neck and the greater tuberosity with the muscles attached to it, and these are set, supraspinatus, infraspinatus, teres minor, and the bicipital groove. We didn't mention the muscles that pass through the bicipital groove. The long head of biceps and the latissimus dorsi muscle is attached to it, and the lesser tuberosity, which is subscapularis muscle, and also mentioned the surgical neck. Again, here, so that would be another right humerus. So this is the right humerus, and you do have here, this is the lesser tubercle for subscapularis muscle. This is the greater tubercle, which is the supraspinatus, the infraspinatus, and the teres minor muscle, and there is the bicipital groove for long head of biceps muscle, and also the latissimus dorsi muscle. And you have the medial lip of biceps and the lateral lip of biceps, of bicipital groove as well. So for this, you have 3 muscles, which we call it a lady between 2 majors. All right, so you have a major and a major as well. So the lateral lip, you have the pectoralis major muscle, and the medial lip, you have the pectoralis, the teres major muscle, and in between is the latissimus dorsi muscle. Factors decreasing stability of the shoulder, we mentioned this, the shallow glenoid cavity and the lax ligaments around it. And then this is the distal humerus. And obviously we need to identify again which is medial, which is lateral, and which is anterior and posterior. So usually the big fossa on the back is called the olecranon fossa, and that is posterior. The olecranon fossa, and that is posterior. And then you have a notch in here, which is called the coronoid notch, all right, from the coronal process. And then you have the capitulum and the trochlea. But before identifying this, try to identify the medial and lateral epicondyle first. So the lateral epicondyle usually more the lateral epicondyle usually is less evident than the medial epicondyle. So look at number 5. This is the lateral epicondyle, and number 7 is the medial epicondyle. Obviously, this is from anterior, and this one is posterior. So I always remember the capital radio. So the capitulum, number 2, is always related to the radius. So if you identify the lateral epicondyle, you will be able to say that this is the next part will be the capitulum because it will be related to the radius. And then 13 is the trochlea, all right? So we mentioned 2 is capitulum, and the 3 is the coronoid fossa, and 4, you can see 4 in here, but 5 is the lateral epicondyle, and 7 is the medial epicondyle, and 10 is the olecranon fossa, and finally the trochlea is number 30. All right, and we'll see this is the right humors. Again, that's from the back. So the medial epicondyle is more evident. Even when you try to feel it in yourself, you'll find that the medial epicondyle where the ulnar nerve is very evident. And related to the lateral epicondyle is always the capitulum, because the radius will be here, and the medial epicondyle related to the trochlea. And here you have the olecranon fossa, as you see here, and that's lateral and medial epicondyle, which is more evident than the lateral epicondyle. And you have here, this is obviously the trochlea, and that will be the capitulum. The supracondylar fracture injury, what will be the complication of that, and what will happen after the supracondylar fracture injury? Before that, we need really to have a quick look on this dissection. So obviously, this is the arm. You have from the top, this is the deltoid muscle. So you have this is the deltoid muscle. And then you have the brachial artery as a continuation of the axillary artery on the lower border of the teres major muscle. So this is the brachial artery in there. All right, that's the brachial artery. Very close related to the brachial artery, the tough structure that looks like a nerve, which is coming all the way from up down, and this is the median nerve. All right, and also the ulnar nerve will be very medial and will pass just behind the medial epicondyle, and the radial nerve will be on the other side, as you see here. All right. So if you have a fracture in this area, and it can be an anterior dislocation or posterior dislocation fracture, it might injure all these structures, and that includes the brachial artery and the median nerve, and sometimes the ulnar nerve or the radial nerve as well. And it's very clear from this dissection. Obviously, this muscle that we cut in there, this looks like the biceps muscle as well. So these are the risk of injury for the supracondylar fracture. You have the brachial artery, the median nerve, the ulnar nerve, and the radial nerve, but mainly those two first. On these markings, so this is the proximal ulna. You have here, this is the olecranon process. That's the olecranon process. And these are the olecranon notch. And that's the coronoid process. This is the ulnar tubercle or tuberosity, and this is the radial tubercle. That's the head of the radius and the neck of the radius as well. This is quite straightforward, just you need to go through them. Again, that's another view for the ulna. So you have, this is the trochlear notch, and this is the coronoid process, which you go to the coronoid fossa, and this is the olecranon right there. And that's the proximal end, and the distal end, you have the head, the styloid process or the ulnar styloid process right there. And then this is the radius, and you have the head of the radius on top, round in shape, and this is the radial tuberosity, and under this, so this is the radial styloid process, and you know that typical Colles fracture can happen in this area. All right. Moving forward, number 2 here is called the Leicester tubercle, and this is obviously the radial styloid process again, and this is called Leicester tubercle. All right. So from 1 to 8, we need to identify the carpal bones. So you have from the lateral to medial, you have initially this is the scaphoid bone, and then you have the lunate, and then you have triquetrum, and then you have the pesiform. All right, the pesiform, and the pesiform represent association to the flexor carpial nares muscle, and then you have trapezium and trapezoid, and then capitate and hamate muscle, right? So if you look at that, there is good articulation between the scaphoid and the capitate directly. This is the identification. Just keep practicing and you'll be able to remember them. But from lateral to medial, scaphoid, lunate, triquetrum pesiform, trapezium trapezoid, capitate hamate, all right? Well, so the blood supply for the scaphoid, as you look here, this is the scaphoid, and the blood supply usually comes from distal to proximal. That's why the scaphoid is always at risk of a vascular necrosis if it has been injured or there is a fracture through it. So it takes blood supply from a palmar and a dorsal branch of the radial artery. So you have here, this is the radial artery, and you have a palmar and a dorsal branch of the radial artery. So if the fracture is there, if there is a fracture in there, that means the proximal part will be deprived its blood supply, and that will be at risk of avascular necrosis. That's why it's quite important to know the blood supply for scaphoid, which is palmar and dorsal branch of the radial artery. So yeah, as you look here, so obviously if this is fractured, we can also in this one identify the bones very quickly. So obviously this is the thumb, so that would be the lateral, and that will be the medial side. And here we need to identify this is a scaphoid, and this is lunate, and this is triquetrum, and that's pisiform, and then trapezium, and then trapezoid, and capitate, and hamate, and this is the hook of the hamate bone. So scaphoid, if it's fractured in here, so this part will be at risk of avascular necrosis. So scaphoid is the most commonly fractured carpal bone, and it can usually happen due to FOOSH, which is full on outstretched hand, and or direct trauma. The imaging at the beginning may appear to be normal. However, when you repeat the imaging later on, you might find that has avascular necrosis. And now we're done with the osteology part, and we're going to continue with the muscles and the rest of the upper limb in the next video. Thank you.